In this video, we'll do an exam review on increased intracranial pressure. Few important exam questions before the start of topic. Question number 1. What's normal and abnormal intracranial pressure? Number 2. What are the clinical features of increased intracranial pressure? Number 3. What are the clinical features at different increased intracranial pressures? Number 4. Which CNS centers are stimulated by increased intracranial pressure? And number 5. What's the treatment of traumatic and non-traumatic head edema? Now, increased intracranial pressure. The contents of the cranial cavity. 80% of the cranial cavity is occupied by the brain, which has a weight of 1400 grams, whereas 10% is occupied by the blood and CSF 150 ml each. The size of the cranial cavity is constant. It cannot be increased or decreased. Increase in size of any of the contents of the cranial cavity, the brain tissue, CSF and blood causes increased intracranial pressure. Now, what's normal and abnormal intracranial pressure? CSF pressure measured in the cranium is intracranial pressure. It's measured in the left ventricle or over the cerebral cortex. So what's normal intracranial pressure? It's 10 millimeters of mercury with an average between 7 to 15 millimeters of mercury or 20 centimeter of water. So the normal intracranial pressure is 10 mmHg or 7 to 15 millimeters of mercury on the average, and a CSF pressure of more than 20 millimeters of mercury is pathological. So what are the effects of increased intracranial pressure? Increased intracranial pressure leads to irreversible brain damage by impairing blood flow to the brain that leads to death. And what's intracranial hypertension? When CSF pressure is more than 35 millimeters of mercury or 300 millimeters of water, then it's called as intracranial hypertension. Remember, normal pressure is 10 millimeters of mercury and intracranial pressure is when the CSF pressure is more than 35 millimeters of mercury. Now, what are the clinical features at different increased intracranial pressures? Intracranial pressure of more than 33 millimeters of mercury causes decreased in cerebral blood flow, and that stimulates the vasomotor center that leads to increase in blood pressure. So normal intracranial pressure 10 millimeters of mercury, more than 20 is pathological, more than 35 is intracranial hypertension, and more than 33 millimeters of mercury decreases the cerebral blood flow and stimulates the vasomotor center to increase the blood pressure. Intracranial pressure of more than 40 to 50 millimeters of mercury causes loss of consciousness, and more than 60 millimeters of mercury may cause death, and more than 80 millimeters of mercury causes brain death. So different levels of intracranial pressure: more than 35 intracranial hypertension, normal being 10, at 40 to 50 it loses the consciousness, more than 60 it causes death, and more than 80 millimeters of mercury causes brain death. Now, causes of increased intracranial pressure: there is an increase in CSF volume. If there is obstruction to CSF flow, that will also cause increased intracranial pressure, or there is decreased CSF absorption or cerebral edema due to infection or tumor, hematoma from intracerebral hemorrhage or subarachnoid hemorrhage, or head trauma, tumor, infections, and fulminant hepatic failure may also lead to increased intracranial pressure. Now, clinical features of increased intracranial pressure. The earliest sign symptom of increased intracranial pressure are disorientation, mental confusion, restlessness, and purposeless movement. Other features are headache, which is worst in the morning, vomiting, which is projectile, and vision is blurred, and there is diplopia, and there is dilated, poorly reactive pupil, and there is papilledema. And what's papilledema? It's bilateral optic disc swelling. So papilledema is always bilateral optic disc swelling, and there are focal neurological deficits and Cushing reflex. And what's Cushing reflex? There is sinus bradycardia due to stimulation of the cardioinhibitory center, and hypertension due to stimulation of the vasomotor center, and there is irregular breathing. So bradycardia due to stimulation of the cardioinhibitory center, and hypertension due to stimulation of the vasoinhibitory center. Amongst the cranial nerve palsies, abducent nerve palsy, the sixth cranial nerve palsy is the most common cranial nerve palsy. There is decreased level of consciousness that leads to coma, and there is decerebrate posturing, and the most dangerous consequence of increased intracranial pressure is cerebral herniation that may lead to respiratory arrest finally. So amongst the causes of increased intracranial pressure are increased CSF volume, obstruction to flow, decreased CSF absorption, cerebral edema, hematoma, trauma, tumor, infection, and fulminant hepatic failure. Amongst the clinical earliest features are disorientation, mental confusion, restlessness and purposeless movements, and headache in the morning, projectile vomiting, diplopia and blurred vision, dilated pupil, and papilledema. Focal neurological features: bradycardia, hypertension, abducent nerve palsy most common, decreased consciousness, decerebrate posturing, and cerebral herniation leading to respiratory arrest. So now, what should be the position of patient in increased intracranial pressure? Pressure is more in lying position than in sitting or standing position. So head should be elevated to 30 degrees. That will decrease the intracranial pressure. Now, what the effects of increased intracranial pressure? Increased intracranial pressure leads to increase in cerebral blood volume. That leads to decreased cerebral perfusion. That leads to further increase in ischemia and causing ischemic brain injury. Decreased cerebral perfusion is the main mechanism of the ischemic brain injury. When intracranial pressure is more than blood pressure, then cerebral circulation ceases. That when intracranial pressure is more than the blood pressure, then it stops the cerebral circulation. Now, effects of increased intracranial pressure on different brain parts. If there is downward displacement of the thalamus, which is in the center, it causes bilateral myotic pupil. Thalamus, it displaces down, it causes pressure on both the CN3 oculomotor nerve. It causes bilateral myotic pupil. The oculomotor nerve supplies pupillary constrictors on both sides, and it forms the efferent limb or the motor limb for the pupillary light reflex. Increased stimulation or irritation causes myotic pupil bilaterally, drowsiness and stupor. Number 2, increased intracranial pressure distorts midbrain and diencephalon anatomy and posterior fossa mass, which causes ataxia, stiffness and nausea. That causes abnormalities of both these areas, midbrain and posterior fossa mass, distort vital brain stem centers and cause obstructive hydrocephalus and brain herniation. Now, upper midbrain lesions, they cause pupillary dilatation, whereas we just learned that the displacement of the thalamus causes bilateral myotic pupil. But upper midbrain cause pupillary dilatation because they interrupt fibers of the oculomotor nerve. Oculomotor nerve supplies the pupillary constriction, so interruption causes dilatation of the pupil because pupillodilator fibers are supplied by the sympathetic division from superior sympathetic ganglia. So upper midbrain lesion causes pupillary dilatation, loss of light reflex. Oculomotor also forms the efferent limb of the light reflex, and loss of vertical and adduction eye movement. Vertical movement to the extraocular muscle is supplied by the oculomotor, and adduction, medial rectus, also supplied by the same muscle. So there is interruption of the fibers of the oculomotor nerve in the upper midbrain lesion. Whereas if there is preservation of the light reflex intact and eye movements, so third nerve is intact with coma. So what does it indicate? It indicates widespread structural lesion of the cerebral hemisphere due to metabolic causes. Now, Uncus compresses the oculomotor nerve, but it causes ipsilateral pupillary dilation, not bilateral. A lesion of the midbrain causes bilateral, as we just learned earlier that lesion of the midbrain causes pupillary dilatation bilaterally. But a lesion of the uncus or pressure on the uncus causes ipsilateral pupillary dilatation because it affects the unilateral oculomotor nerve. Now, displacement of the medial temporal lobe compresses oculomotor nerve and cerebral peduncles. That leads to ipsilateral pupillary dilatation and contralateral hemiparesis. We have discussed this on the midbrain syndromes and have separate videos videos, so please watch them for further details. So medial temporal lobe compresses the third nerve and causes ipsilateral pupillary dilation and contralateral hemiparesis. Progressive compression of the brainstem damages midbrain, then pons, and finally medulla. So compression first damages the midbrain, then pons, and finally medulla, and then it herniates, causing respiratory arrest. An acutely enlarging mass causing horizontal displacement of the pineal gland of more than 3 mm causes drowsiness, more than 6 to 8 mm causes stupor, and more than 9 mm it causes coma. So pineal gland displacement, if more than 3 mm, drowsiness, more than 6 to 8 mm, stupor, and more than 9 mm causes coma. So what's the difference between stupor and coma? Coma is deep sleep, patient cannot be aroused, and stupor is higher degree of arousability and patient is transiently awakened by vigorous stimuli. Now next is cingulate gyrus displacement. It causes anterior cerebral artery compression. We have a separate video on brain strokes and cerebral artery compression. Please watch that. And as I already earlier explained, posterior fossa mass causes ataxia, stiffness, and nausea. Now treatment of the increased intracranial pressure. Intoxication may cause head injury, so test for drug and alcohol. Number 2, raise the head of the bed. Head should be elevated to 30 degrees. Why? Because it decreases the intracranial pressure, because intracranial pressure is maximum in lying position. Now what's the treatment of traumatic and non-traumatic edema? For edema of head trauma and stroke, the treatment is osmotherapy or osmotic diuretics. So this is the treatment for head trauma and stroke, osmotherapy, to maintain the serum osmolality to less than 320 milliosmoles, and the drug used are mannitol and hypertonic saline 30 ml. So to treat edema of head trauma and stroke, mannitol and hypertonic saline, and for non-traumatic and non-stroke edema, dexamethasone 4 mg 6 hourly. Glucocorticoids are avoided in head trauma and stroke. Treatment for the head trauma and stroke edema, as already explained, is mannitol and hypertonic saline, osmotherapy or osmotic dilatation. For sedation, morphine or midazolam is given. To decrease the intracranial pressure, vasopressors are also used. So what do? Vasopressor increase the mean arterial blood pressure. That leads to increased blood pressure. That leads to decreased intracranial pressure, and that increased cerebral perfusion. So vasopressor are used in increased intracranial pressure because they decrease the intracranial pressure by increasing the blood pressure. That leads to decreased intracranial pressure. Decreased intracranial pressure leads to increased perfusion, and the vasopressor drugs used are phenylephrine, epinephrine, and dopamine. PaCO2, carbon dioxide, is maintained at 30 to 35 millimeters of mercury, and free water is restricted. Treatment of cerebellar stroke is by decompression of the intracranial contents by emergency surgery. We already had a hemorrhagic stroke treatment separate video. Please watch for further details that video. Ventricular catheterization is done for hydrocephalus, and spinal cord injury often accompanies the head injuries that may cause spinal cord compression. So spinal cord here should also be done. Now treatment of the refractory increased intracranial pressure. High dose barbiturate, pentobarb example. Hyperventilation is done, but is done for short period only to maintain PaCO2 at more than 30 millimeters of mercury. Hypothermia is done, and hemicraniotomy may also be done. Now answers to the questions. Question 1. What's normal and abnormal intracranial pressure? CSF pressure measured in the cranium is intracranial pressure and is measured in the left ventricle or over the cerebral cortex. Normal intracranial pressure is 10 millimeters of mercury with an average of 7 to 15 millimeters of mercury. CSF pressure more than 20 millimeters mercury is pathological. Increased intracranial pressure results in irreversible brain damage by impairing blood flow to the brain, leading to death. Question 2. What are the clinical features of increased intracranial pressure? Early signs and symptoms are disorientation, mental confusion, restlessness, and purposeless movements. As earlier mentioned, headache is first in the morning, vomiting is projected tactile, and the vision is blurred with dilated poorly reactive pupil and diplopia and papilledema, focal neurological deficit and pushing reflex, bradycardia, hypertension and irregular breathing, cranial nerve palsies, most commonly abducent nerve palsies, decerebrate posturing and cerebral herniation. Intracranial pressure more than 33 millimeters of mercury decreases cerebral blood flow, stimulates vasomotor center that increases the blood pressure, and CSF of more than 35 is intracranial hypertension. Intracranial pressure of more than 40 to 50 causes loss of consciousness, more than 60 causes death, and more than 80 causes brain death. Question 4. Which CNS centers are stimulated by increased intracranial pressure? Number 1. Vasomotor center. Stimulation increases systemic blood pressure that maintains cerebral blood flow. And number 2. Stimulation of cardioinhibitory center causes bradycardia. Question 5. What's the treatment of traumatic and non-traumatic head edema? For edema of head trauma and stroke, osmotherapy is done with mannitol and hypertonic saline, and serum osmolality is maintained less than 320 milliosmoles. And for non-traumatic and non-stroke edema, dexamethasone 4 mg 6 hourly is given. Glucocorticoids are avoided in head trauma and stroke.